I am a hospital-based case manager at Mid Coast Hospital, and I want to welcome everybody and say Happy Case Management Week. I want to take this opportunity to thank the Highlands for sponsoring this program and introduce Amy Barabee, who is the Director of Community Relations at the Highlands, which is a GRACE community in the Mid Coast area. Amy.
Hi, everyone. Happy Case Management Week. Oh, I guess the post office. I thought it might be an ambulance out there and warn you, Cindy. The Highlands is a private pay retirement community here in Topsom, Maine. We've been very privileged to enjoy a partnership with Mid Coast Parkview Health and enjoy such services as a primary care provider office just outside of our campus, on-site physical therapy service office, also offered by Mid Coast Parkview Health, and a very strong relationship with their home care and hospice agency, which is how we have come to be such great proponents of Dr. DeMars and his work. We're honored to support today's webinar and hope that you enjoy learning from one of the finest providers that we work with in the area. He is very knowledgeable, incredibly capable, a great educator. And again, thank you for this opportunity.
All right, and now it is my pleasure to introduce Dr. Carl DeMars, who is a palliative care physician here at Mid Coast Hospital in Brunswick, Maine. He has been a primary care physician in his current position for the last 18 years. And he is also in an administration and is the Vice President of Ambulatory Care Providers at Mid Coast Parkview Health. Dr. DeMars is not an advocate for death with dignity laws or policy, but he feels that since it is the law that the patients and families, patients and families have the right to the best clinical guidance for this difficult decision. So, Dr. DeMars, take it away.
Thank you, Cindy, and I will start my slides in a second, but I just wanted to again say, happy Case Managers Week. This is a privilege for me to talk to all of you. I absolutely cannot do what I do in palliative care without the case management team, and we work hand in glove, and hopefully those of you that are in other systems work closely with your palliative teams. It's really an incredible co-management of patients that really gets the best of it all. And thank you again to the Highlands for their, Amy's kind words and really being an advocate for excellent care in the Mid Coast. I'm going to share my screen here. So I'm going to start here just by again saying I'm not an advocate for these patients that are choosing this. This is a law in the state of Maine and also in our state of Vermont that you guys are part of representing. And when this came to be in the state of Maine, it became very evident to me that while we can pass laws, actually how to operationalize this, what I consider the most complex at-home intervention that you can do with a patient, really needed a lot more study and education. And so I'll talk about in the slide presentation kind of how I went about doing that, and then what is happening today to connect us to the Western states that have been doing this the longest. Early on in the discussions with the team here, there was questions about what about the rest of the New England states. And so as I said, Vermont has passed a law. Currently, Vermont has another addendum to their law as these laws are changing currently in their legislature. New Hampshire did have a proposal that did not make it through in 2020. Connecticut had a proposal in 2021. I know Connecticut's not represented here, but it is part of New England. Rhode Island has a law right now in committee, and it's awaiting further study. And in Massachusetts, there is an active law going through committees and further study, and many articles if you do a Google search like I did before this. So I guess what I'm saying is that there are a lot of states considering this. Right now it's legal in 9 states across the United States. Those are California, Colorado, Oregon, Washington out west, New Mexico is the newest state, Hawaii, District of Columbia, and then more on the East Coast here, Vermont, Maine, and New Jersey. And so I do think we're going to see this kind of continue to grow across the United States, and we would anticipate that they will all be similar laws as they've all kind of copied one another. And we're going to go through the law here in a second. So just a brief mention of what we have here at the Mid Coast Palliative Care. So we're about a 100-bed hospital. We have a medical group of about 140 providers, and Palliative Care has been really supported by our senior management. We have 3 physicians that currently are staffing this. They're not full-time. We all have something else that we do, but together we make about a full FTE of physician, and then a full FTE of nurse practitioner and Maggie Gardner. And we have a social worker that's part of our team. We do provide inpatient consultation now 365 days of the year. We are on call also at night if our teams need us. And we also now have an outpatient clinic for palliative care, 2 days a week up the hill here at an office, and then a half day with our cancer partners. We also do home visits. We go to assisted living, nursing homes, and patients' own homes to do palliative care. So just wanted to introduce that for a minute. Please interrupt at any point with a question. Cindy will stop me and kind of nudge me to say there's a question. I'll try to take a pause in the spots where I think we may have stirred up some questions. And I do want to make it as interactive as possible, since it's a difficult Zoom world, but I do think it's important that I hear what your questions are. So right into the law here, death with dignity, DWD is the term. I will say that in my learnings out west, medical aid in dying is a much better term than death with dignity. Death with dignity implies that a dignified death is only possible through this means, and that's absolutely farthest from the truth. We have excellent hospice care and palliative care that we can give patients, and we would like to kind of change the verbiage here if we can. But right now, the law in Maine is called the Death with Dignity Law. So you have to be an adult, 18 years, and a resident of Maine. Most of these laws don't have stringent residency requirements. For Maine, you can be a summer resident, you can own some property. You can't move to Maine for the sole purpose of accessing this law. You have to have a 6-month prognosis. This is the same as anybody that comes on to hospice. I will say that being a clinician that works with patients that are trying to access this law, my bar for saying that somebody has 6 months is a little higher than for hospice. And yes, they're both the same, but I take very seriously the seriousness of making this decision. And I really want to make sure that the 6-month prognosis is really pretty solid before we go forward. In the law, it says you have to be competent. Those of us that look at this really would prefer the word capacity, a capacity to make an informed decision. We discuss this a lot in all of our work as case managers and physicians and other people that are involved with patients when they can no longer make their own decisions and they lack capacity. So they do have to have capacity. You don't absolutely positively have to have a psychiatrist or a psychologist evaluate somebody for capacity. Any provider can do that. But you do have the ability to refer to a mental health provider if you need the extra level of support. And then you need to be not suffering from a very severe psychiatric or psychological disorder. Now, you can be depressed when you're dying. That's something we see pretty frequently, but that depression can't be affecting your judgment. And that's a bit of a gray zone there, but if there is any question, referring to a local mental health provider is helpful. I do have a behavioral health clinician that works with me that is able to help do this via telehealth if I have any questions. And then lastly, this is going to be interesting later on as we kind of dive into the weeds of this law. You have to be able to self-administer medicine into the GI tract. And the law uses the word ingest in Maine. And so, again, oral and PEG tube administration are 2 places that are pretty widely accepted. Right now, discussions about the rectal administration for those that cannot swallow, that don't have a feeding tube, that may otherwise qualify for the law, is being considered under our policy. But many states, that is about 1 out of 6 ingestions are rectally through a catheter. So what is the process? So a patient will go to their usually their primary care, their specialists, and that specialist or primary care oftentimes will say, you know what, I'm not comfortable with doing this, and I've tried to, in the state of Maine, let my provider partners know that I can help. So oftentimes the patient will then present to me as a consult in palliative care. First thing that has to happen is a verbal request for this process, and the attending physician, which is the one that will be prescribing the medicine, will do the kind of go through the capacity question, the 6-month question, the depression question, and really make sure that this person would qualify under the law. From the very, very beginning, I spend a lot of time explaining the red flags and the times that I'm worried that the medication may not be the most appropriate with people that can't absorb an oral medication, and really describing kind of what my worries are. And also from the very, very beginning, say you have the right to rescind this request at any time along the process, up to and including the day of ingestion. So what then happens if you've taken that verbal request from the patient, there's nothing written at that time, there's the note that I write as a physician, a referral or an examination by a consulting physician. And oftentimes what I will do is utilize the patient's PCP or whoever referred the patient to me to say, can you again corroborate this 6-month prognosis, the capacity question, the depression question? And there is a form the state has for them to fill out that then gets faxed back to me as part of the documentation for the state. At least 15 days, and this is a bit arbitrary, but this is what most of the laws have, is a 15-day waiting period from the first verbal request to the second verbal request. There is a second verbal request and then a written request, which is a form, and I'll show you later on what that form looks like for the patient to fill out, that is witnessed by 2 people. So after that form is signed and witnessed and the verbal request is documented, there's a 48-hour wait period before the medication can be prescribed. So it's about 17 days from the beginning of this process to the end for the earliest somebody could ingest. It's of note that people that seek out this process oftentimes will be very close to the end of life, and a significant amount of them will pass away in this 17-day period. There is now a couple states that allow emergency access, that you don't have to wait 15 days if somebody is actively, approaching the dying process, but that is not the law currently in the state of Maine. So again, what does that attending physician do? They evaluate the patient, they ensure the criteria is met, they coordinate with the consultant, they complete all the required document, and counsel the patient. I think that it's important, if you get anything from this talk, that you have the website, the ACAMAID, that's the American Clinicians Academy on Medical Aid in Dying.org. On that website, you will find a lot of patient education materials, and you will also find a video of ingestion from an actress and her family, just to have people understand what this process looks like. So that is one place that I send all patients and families to really understand this process. And then I oftentimes think it's best for us to continue to have team-based care with a hospice team. I think that this patient is choosing to possibly use this medicine, is still going through a dying process. The family is still bereaved, and we really need good communication and coordination from a hospice team. So I really try to make sure I enroll everybody in hospice that chooses to go down this pathway. The consultant, I just real briefly, is again, they do the documentation and send it on to the attending physician. So again, here's where I kind of had a sea change in my interaction with patients that are trying to access this law in the state of Maine. I went out to this conference wanting to learn more about the actual operations of how patients were going to do this. I had been part of the Maine Hospital Association and making statewide policy, and for my parent organization, Maine Health, for making policy for our clinicians. And there's obviously not a lot of knowledge here in the state of Maine about how to do this. And so myself and another physician from Maine flew out to California and spent a couple of days in Berkeley with teams that have been doing this for a long, long time. And this is what I learned. Many clinicians in states that have been participating in medical aid in dying have significant research. Now, this is not double-blind, placebo-controlled trials. As you can imagine, nobody has actually really done those kind of trials with medications to end a person's life. This is honestly some trial and error and some bedside research that showed how the medications that we're going to describe in a minute have been changed over time to be the most effective medications. The second thing I learned is that the process is incredibly complex, that these patients and their families need really robust support through this process. They're scared, they're trying to gain control over their disease, and really a team-based care is required, like hospice, with interacting with a provider like myself that is knowledgeable. And the key to the entire thing is the ability to absorb this medication into the GI tract. Without that, it is not going to be effective. So let's talk about the medications themselves. So this is the third change to medications since that February conference, which, if you'll notice, was right before COVID. I was flying home from California as the news was breaking. And so, it hasn't been that long ago that I went out there, and again, 3 changes in these medications. So right now, if you look at these doses of medicine, those that are clinical can really see that these are tremendous doses of medications. I tell people that if you actually took the actual tablets to go through this process, it would be over 4,000 tablets of the commercially available products. So you really need to partner with a local pharmacy that can compound inside of a hood. So the pharmacists and the techs do not breathe in these chemicals. They are obtained by their raw powder form from the manufacturer. And really, again, the education of patients and families about the dangerous medications that could be on somebody's nightstand is done. I'll talk a little bit about that in a second. But again, digoxin and amitriptyline are the drugs that stop the heart, and the diazepam, morphine, and phenobarbital, the medicines that put the patients to sleep. So what really happens is that first there's some nausea medicine taking. It's two prescription drugs in tablet form, ondansetron and metoclopramide, that are taken about an hour prior to the intention to ingest this cocktail of 5 medicines. These 5 medicines are in a bottle and mixed with water or clear apple juice. They're resuspended and then put in a juice glass, and the patient then tries to drink them as quickly as possible. When I say as quickly as possible, it is because the amitriptyline portion can really burn the throat, and some patients have a hard time taking down the entirety of this medication. So practicing with 4 ounces of liquid, describing the burning, talking about using some sorbet after swallowing so that the throat is cooled is all important to educate the patient and family. Again, we talked about the compounding need for this and the cost. It's not covered by insurance in any way, shape, or form. It's about $375 here in the state of Maine. And the mean time to death is about 1.1 hours. And let's see if my next slide says it. Yes, it does. So really, how does this medicine work? Patients will be fully asleep, in my experience, within 5 minutes. They say up to 20 minutes, but every patient that I've been in attendance of has been totally comatose within 3 to 5 minutes. So having them ingest the medication in bed and having everybody ready to witness what is a relatively quick comatose state. And then about 40% will die in that first hour from respiratory depression. About 90% will die within 2 hours from the arrhythmia from the medication. Although you have to warn people, and I'm now counseling people, that about 10% of patients will live over 2 hours after ingestion, usually with agonal breathing, like you would watch another patient who's in the dying process, up to a maximum of 16 hours. There have been reports of patients that this was not successful. I have not seen any in Maine, as the medicines have been changed over time. But again, getting the medications absorbed and knowing who is not going to be a good candidate, I think, is really, really important. We're going to talk about those here in a second. I'm going to stop, Cindy, and see if there's any questions about the law process or this first piece of information about the medications.
We don't have any questions in the question and answer as
Okay.
of now.
I will continue. Hopefully you guys do come up with some questions at the end, because I think it's important for us to clarify anything I'm being less than clear about. So let's talk about those red flag patients for a second. So honestly, when you think about this, it's anybody with the inability to absorb the medication. Cachexia or people that have not been getting good nutrition. They lack the ability to absorb. Gastroparesis, severe constipation, bowel obstructions, cancers that affect the GI tract, ascites that is tense. These are all people that I would really want to counsel that this may not be the best process for us to undergo. People that can't swallow effectively. There's a patient right now that I have that has severe Parkinson's that had wanted to proceed with this, and I'm really counseling against it because they really cannot swallow in the rapidity that you need to be sure that the medication will be absorbed. And then people that have very high opiate or benzodiazepine tolerance may take longer to fall asleep. People that have healthy hearts or are extremely obese can be also a longer time, or people that abuse alcohol. So I'm not going to necessarily go deeply into each one of these things because this is very weedsy, but I think it just shows you how complex this process is. It's really, having good communication with the patient and their families. When they come to see me, many patients are looking for control. They are actually not ready to ingest. And sometimes it'll be many months before they may be ready to ingest, or they never actually ingest. They die the hospice death. But it's really important to stay in contact because being prepared for the day of ingestion is really, really important. So letting the hospice team know that this patient may be considering this, giving them my contact information so they can reach out to me. One of the things that I do is the pharmacy that we use here at the Mid Coast region is down in Portland. And I actually have them hold the prescription, the paper prescription, until the patient says we're close to being ready to ingest, so that medicine is not sitting in someone's home. When somebody calls to pick it up, that pharmacist will send me an email saying Mrs. Jones picked up the medicine. That's another cue for me to tune in again and see how the family is doing. Again, talking about practicing the swallowing, using some thickened liquids, I think is important. Making sure the bowels are clear and passing on a regular basis, I think is important. And then the day before, really using all the regular medicines and then having a liquid diet the night of prior to the ingestion. Really not having a severely fatty food meal is important. And then the morning of the actual ingestion, it's only clear liquids and just sips at that time. On the day, it's important to counsel the family because they're going to be mixing the medicine. The law stipulates that nobody can actively participate. So that means I, as the physician or the hospice team, cannot help mix the medicine. We can be present and talk them through it, but I cannot sit there and help them mix it. So really making sure that we're not contaminating other areas of the kitchen and watching pets and kids closely. You can see here about, paper towels and plastic bags to make sure we put the stuff away in a very careful way. And then really about, again, opening the bottle carefully, putting in the apple juice mix, and then put into a glass cup. This is all on that same website. So I'd like to talk now and pivot, but I'm going to stop again, Cindy, and see if we've stirred up any questions or thoughts.
Nope, still no questions.
Okay. Well, I'm going to talk about the human experience that I've had with a few patients. And again, when I started becoming involved in this and I went to that conference, it became one particular vignette that was shared via video was a daughter of a woman that did this by herself and talked about how it went so poorly and how all alone she was and how scared she was. And it became very evident to me that in our patients' deepest times of need, they really need somebody to calm them down. And different states have done different things. Washington has a volunteer organization that sends patients to the bedside that have been trained. Here in Maine, I've attended probably 6 or 7 of these ingestions and continued to talk to people across the state about how to support people. My first patient was Bob. It's not his real name. He was a Navy veteran and had an incredible story that was very touching, that he then became a peace activist. And he was a homesteader building his own house on one of the islands here in Maine. He was suffering from early dementia, and this is one of those things that, again, dementia by itself being an end-of-life reason, you couldn't access this law because you would lack capacity by the time you were 6 months. But Bob had something else going on, and I followed him for about 8 months prior to okaying this process, and it was evident that he was functionally declining and he was losing a ton of weight. I think he may have been 85 pounds when we finally went forward with qualifying him. He was incredibly steadfast. People that make this decision tend to be really steadfast in the decision that they don't want to be dependent on others or be a burden, in their words. As we approached the day of death, the entire family was present. They did allow me to be present along with my hospice team. I again talked about his ability to rescind his decision. At that time, the digoxin was taken at a separate time. So it was a 30-minute after antiemetics for the digoxin, and the phenobarbital was not part of it. The patient actually was totally obtunded within 4 minutes. His family laid in the bed with him and cried, and he was gone in 10 minutes. And it was incredibly powerful for all of us in attendance to watch what happened and the control he got over his end of life, and how thankful his family was. And I kind of naively thought that this might be what we see in all the patients that we interact with. But my second patient, Joe, who was a plumber, made a decision that he didn't want to continue and be a burden, and his Parkinson's and function decline got to the point where he was definitely less than 6 months. And we picked a day to go out there. He didn't want his kids there, but his wife was there with us. The patient had taken the antiemetics, and again, he quickly became obtunded, but it was about 4 hours of agonal breathing for this relatively cachectic man to finally pass. And that's a hard 4 hours to bear witness and to be with a family as you're sitting there. And oftentimes they'll turn and say, why is it taking so long? Or why can't we do this like a pet? And I have to just, counsel them that this is what is the current law, and we will, he doesn't feel it, and we are supporting the family. Since this time, I've had times of ingestion from 20 minutes to 15 hours with somebody who did not have an empty stomach and was young. And so these long times can be very, very trying for the patient and family. So preparing them ahead of time, I think, is quite important. Cindy?
Yep. You have a couple of questions here. The first one being, does a doctor have to be present during ingestion?
Excellent question. The doctor does not have to be present for ingestion. In fact, many doctors have a hard time being present. I think it's important that we give the patients and their families some sort of support. And so I oftentimes will be talking to my hospice colleagues across the state, or another physician who may not have done this. I actually did this today with a physician down in Portland who will be attending, and she just wanted to make sure, once again, that she had everything straight. And so I'll give them my cell phone. But, patients can say, we don't want anybody, and there's no requirement that somebody is there. Sometimes families do have people in the healthcare field that they feel very comfortable with, or they feel just very personal about this.
And then there is another question. It says, can any provider offer this service to a patient, or do you need to be a palliative specialist or have special training?
So the law states it has to be a physician. It does not have to be any particular specialty of physician. It can be any physician. It cannot be a nurse practitioner or a PA. And that's pretty consistent that I've seen across the country. There may be one state that's allowing some APPs to do this, but currently in the state of Maine, that is the case. I will say there is a nurse practitioner up the coast who does not have a physician that is willing to work with her. And I've worked with her to be the prescribing provider and to walk through it with her patients. And then she actually attends the ingestion. And we've been able to work through it that way.
Part of that same question was, can providers refuse to follow patient wishes without any consequences?
So providers are not required to participate when a patient makes a request. There is something in the law about offering to refer them to somebody who will, but that's not currently known by many of the providers, so I don't know how they will enforce that. I ethically believe strongly that nobody in any part of the healthcare system should be forced to assist or be taking part in any part of this process if they have ethical or moral or religious objections. And so I've talked to my hospice team about, if you do not feel comfortable, then we're going to switch the nurse out. Anybody, please do not feel like you have to do this. And that's part of the policy that we made at Maine Health and across the state of Maine. Seeing you turn your camera off, I guess that's the end of the questions. I'll continue on. So death certificates, if the patient has passed, providers should not use the word suicide or suicide as a diagnosis. It's really not good to do that. Really, I recommend using the terminal diagnosis as you would with a natural death. Some providers really do want to include some specific terminology, and this is what we decided at the policy level is self-administration of medication associated with Maine Death with Dignity Act. I think this is a good time before I go into the forms, just to briefly talk about location of ingestion, as many of you may work in facilities that are taking federal funds, and those places are very, very much against taking and having patients ingest in their facilities. And the federal government has taken a stand that no federal dollars can be used towards death with dignity, and that's pretty clear. So I will say that most long-term care facilities and hospitals will not allow ingestion, but I will say assisted living facilities are taking this as a case-by-case, especially those that are self-pay, as this is a resident's home, their apartment, and really trying to work through that. So we've had a few people that have actually ingested in an assisted living facility in the state of Maine. So here's the forms. Again, they're not important to go through the entirety of these forms. Really, this is the patient form. Just has the places for them to say whether they inform their family or not. It's not required that you inform your family, but it certainly is recommended. The witnesses, one of the two witnesses cannot be a family member or the attending physician. So if patients are doing this in my office and they've come to my office, I actually have our office staff witness the signature, and that witness is only that the person signing is actually the person, not that they've gone through any other the 6-month prognosis or anything like that. Here's the form that is filled out at the very end, talking about the end-of-life diagnosis and all the things that are required from the attending physician. This form is actually 2 more pages long. Yeah, this is the second page, I believe, here. Oh, this is the consulting physician. I'm sorry. This is the consultant physician one that they sign, and then this is the attending one that's got another whole page to fill out. So there's 4 forms that are required for the state of Maine. And here's the End of Life Closure Act. You do have to inform the state of when you write the prescription, and then after writing the prescription, this End of Life Closure form, or it's been 6 months since writing the prescription, to let the state know what's happening. They are keeping track of how many people are asking for the medication and how many people have actually taken it. This link here is a link to the video at that ACA MAID site.
We're doing okay. So let's go in the living room.
Good to see you.
Hey, I'm Thalia.
Yeah.
Nice to meet you, Dare.
Dare, nice to meet you.
I'm not too sure about all this, so.
I understand.
Okay.
It's a pretty big day. I'll be right here the whole time for all of you guys, and we'll just talk you through it.
Okay.
I know you guys read the instructions. Do you have any questions for me?
They were very thorough, and we gave her the 3 anti-nausea tablets about an hour ago.
And just to be sure, I know you guys had a little dog here. Are all the pets put away? I'm going to be carrying really lethal medication that I don't want to trip.
Rusty is at the neighbors, and we actually brought the grandkids over there too.
Well, why don't I put my stuff in the kitchen and we can head upstairs. Hey, Roberta, how are you?
Ready for the journey.
I'm so glad. I want to sort of bring you guys in close. Everybody get comfortable, because it can take some time. I just want to check, first of all, that you're absolutely sure that today is the day that you're ready to really die. You can send me home right now if you've changed your mind.
I understand, and I am ready.
All right, I just wanted to be sure.
Thank you.
Yeah. I'm going to go get the medications.
I know you need to do this, but I'll be with you in other ways. Okay?
Yeah.
I love you.
I love you.
Some nurses and many bedside attendants are not allowed by their institution to mix medications. If that is the case, then make sure whoever is going to mix the medications is prepared to manage this safely. They should have gloves, a catheter-tipped syringe or a small measuring cup, clear filtered apple juice, paper towels, and a small garbage bag. This video is about how to mix medication for oral administration of medical aid in dying. I've put down a little barrier. You can use paper towels, that's fine. You're going to need a measuring cup or something that has a little spout. You're not actually going to measure anything, but you want something that's easy to pour. You're going to need some clear filtered apple juice, the medications, and the glass that the patient is going to be drinking out of, and some gloves. You're going to put on your gloves. The most crucial part of mixing these medications, and to do so safely, is that we're going to mix the medications directly into the bottle. We're not going to take the bottle and pour the powder out into the glass because that could be dangerous. The powder might aerosolize and expose you to medications. So you're going to pour your apple juice first out into your measuring cup. Then take your bottle and just tap it so all the powder falls to the bottom. Then you're going to take the top off carefully. You can see there's a little bit of medication around the top. Now you're going to fill the bottle just about halfway. Then cap the bottle and shake it. Be sure you get all the medication, especially off the bottom, and then you're going to uncap it and fill it the rest of the way, right up to the neck of the bottle. Then cap it, and you'll take the bottle and the glass up to the patient's bedside. Okay, Roberta, this is your final 4-ounce medication. You ready?
Sure. I have to sit up more to drink it.
It's pretty bitter. It might burn a little bit. Completely finish all the 4 ounces as quickly as you can without coughing. And very soon after that, you'll get a mouthful of sweet, cool sorbet. Okay? When you're ready.
Mom, you were worried about that part.
It's good. Euphoria, you said.
Mm-hmm. You feel a little floaty.
It's getting a little close.
We'll always be with you, and you'll always be with us.
I love you girls. I'm so glad we've had our life together. I'm gonna slide down a little more.
I think she's getting pretty drifty. Roberta, can you still hear me? Just barely still with us. Getting really comfortable now. All right, I'm just going to check and see if she's still awake. Oh, I think she's pretty asleep now. You might hear some really strange breathing. She might take a very sudden deep breath. Those are called agonal breaths. It's just a normal part of dying. Roberta is comatose. She is really sound asleep, and if she has any strange breathing, she won't feel it. It's all right. It's just a normal part of dying. It's just an agonal breath. You see how relaxed her face is? Yeah. That's just one little agonal breath. It's okay. Yeah, you stay close. She's all right. Okay. Looks like she's stopped breathing. Okay, I'm just going to check her pulse. I don't feel any pulse. Let me just be sure. She's gone. Roberta has died. I'm going to leave you guys alone. I'll be in the next room.
Thank you.
My share now. I can always open it back up if there's questions. So Lisa Nickerson says, curious, what would the death certificate say? I listed that. And is there impact on life insurance? The answer is no. They actually took pains with the law to say you cannot refuse life insurance for people that choose this process. So I know we're not sharing cameras. Can a legal guardian make a decision for medical aid in dying by Doug? No, a legal guardian cannot. It has to be patient initiated. Now, this gets into what about those patients that are nonverbal? What are the ones that have ALS at the point where they can't communicate in the same ways? And there's actually a lawsuit in California for disabled people that they want the same access to this process as anybody else. And so, you know, these are things that we need to kind of work through. So again, the legal guardian cannot make the decision for medical aid in dying. Bernadette Fox says, since this law went into effect, approximately how many patients have completed this process? So I believe in the state of Maine last year, there was maybe somewhat like 30 people that started the process and maybe 20 that went through the entirety. I kind of calculated our population in Maine compared to Washington that's had the law for a long time. I would anticipate in the coming years, we'll have about 70 patients complete the death with dignity process and ingest the medications as their choice here in the state of Maine. So it's not a huge number, but it's not a small number either. And each one of these represent a challenge as they oftentimes bring up a new wrinkle, like the rectal administration that we talked about earlier. I'd be interested to hear if anybody on this call has had patients or other people ask about death with dignity in their arenas.
Dr. DeMars, how many agencies do you think are offering this in the state of Maine?
When you say agencies, Cindy, are you talking about health systems?
Yeah, like if you were a patient outside of the Mid Coast area, would physicians refer to you, or how does that work?
So it's been eye-opening for me that people that have accessed their own physician and that physician is willing to participate for just their own physician has not been as high of a bar as people that their own physician is uncomfortable, and then they start out searching for a physician that will prescribe, and they'll find very quickly that believe it or not, I'm the only doctor in Maine that currently will help people that don't have a prescribing physician. And so it's a concern for me, considering the size of Maine, my administrative job, again, not wanting to be an advocate, but also wanting to make sure that somebody up at Fort Kent has the same access to the process that we're talking about. And my goal is to educate one or two people in each local health system to be able to form a community. And that's what's happened in other states, is somebody's been able to help other clinicians that are scared but ready to help. I am part of a nationwide group of physicians that prescribe that get together every other month on a Zoom call. So it's from Hawaii to Maine to hear about the issues that are taking place in their organizations. Kimberly was brave enough to say, I care manage oncology patients and have been asked about this. I had one patient that asked and went through the process, but did not use it. And again, I would say 25% to 30% of my patients that go through the process that aren't dying quickly choose a hospice death, and they don't use the medications. It seems to be about control.
Have you ever had an issue, Dr. DeMars, with a patient requesting assistance in doing this and family fighting them, not wanting them to do it?
I have not had an instance where somebody overtly was being really tough on their loved one about this. I certainly have instances where families are concerned and want to talk it through, and we do what we do in palliative care a lot. We have family meetings, we sit down, we talk it through, and we've been able to get to consensus. But I'm sure there'll be a day where we have a family member who's just not happy about this and may cause, you know, the family person to have a problem. Amy says we have a lot of residents here at the Highlands 55 plus who are interested in having the right and are big proponents of death with dignity, but none that I know of who are at a point of wanting to follow through with the process. It's, I guess, interesting as I studied this that the public perception, so back in the 30s and 40s when they started asking about what was then described as euthanasia, about 35% of people supported it. Now about 75% support the right to die with their own medications if you look at the population at large. These laws first started coming out as citizen initiative ballots, but increasingly, including the state of Maine, they've gone through the legislative process where somebody will bring up a bill, they'll debate it, and then it'll become law, not using the ballot process.
You do have some questions in the question box.
Oh,
Dr.
look at that.
DeMars.
So Nanette Wood asks, a person documents in their advanced living that they would want this if they were in certain circumstances could not speak. Would that be honored if the power of attorney or medical were advocating for it to be carried out? The answer is no. You cannot self-determine this. It's totally at the moment of the first verbal request where you have to have capacity and ability to go through the process. You cannot predetermine this. And of course, you think about some of the diseases that people would want to consider this for, dementia being the one that kind of calls out to me about not wanting to be a burden on people and live in that way. Jeanette Erskine says, I actually had a patient and spouse that wanted information on DWD. However, I work for the federal government. We do not recognize the law. However, because of that question, to me, I think it's important to know and learn about this law. So thank you for this education. Well, Janet, thank you for your advocacy for your patients. And I think that simply referring them to the ACA MAID site, you'll find that they have a lot of information there. And also on that, there is a link that people can request if they cannot find a provider, that agency out in California will go ahead and connect to providers in that state. So I have been connected through that process for people that could not find somebody that weren't part of Maine Health or anything else that I've been able to help. And so that is another place you can send them. Anonymous, what is the response by Maine providers? Medical marijuana Spoxman slow to take hold of the providers. Anonymous, you're absolutely correct that the providers, while certainly understanding of patients' desires for this, are very hesitant to take part in this. Some are, ethically and morally against it, which is totally their right. Others are still just trying to see how the process plays out and are understanding the complexity. So Doug asked me, what is the next step to expanding this law in Maine, if any, what needs to be added to the law? I will say that the original author of the law came to see me a couple months ago to ask my experiences. I sat with her and went through the things I've talked to you all about tonight. She said that if we open this back up, there's a chance that the whole thing could be rescinded, and that's a real risk. And so if something isn't absolutely positively needs to be changed, we shouldn't change it. But to answer your question, I think those people that qualify but maybe dying quickly within the 17 days, that's one place the states are changing the law. Barbara Colshaw mentions what happens when by the time a patient's 6-month terminal, but by that time lost power of handling meds, mixing, et cetera, the patient meets all other requirements. Barbara, I don't know the answer to this question. I try to stay in contact with the patients. I try to tell them that it's not a good idea for us to have patients that don't qualify on day of ingestion to be ingesting the medicines. That being said, I cannot stop them once they've actually gone out and I've written the prescription from having the medication and taking it. And so that is a fear of mine, that there's those patients that may no longer qualify but still have the medication, and we'll continue to just try to educate the best we can. So if there are any questions that we were not really feeling comfortable asking in a group format, certainly Cindy can take emails from you all and forward them on to me. If people in other areas want to talk offline about our experiences here, I am happy to talk about them. Again, not as an advocate, but as you can see, this is a very complex and kind of sticky process that you really need to partner with all aspects of the health system to be able to help patients and their families. It's not just as simple as, I talk about Snow White and taking the potion and falling asleep and not waking up. And that's what people have in their minds. We have to understand that's what's in their minds. That is not the reality of what they go through.
Thank you, Dr. DeMars. That was really, really informative. Any other questions from participants? All right, well, I would like to thank Dr. DeMars for speaking to us tonight, and thank Amy Barabee and the Highlands for being our sponsor. And as an inpatient case manager in acute care, I am so fortunate that I have this wonderful palliative care team to help patients and their families through difficult decisions. And we don't do a lot of this work in the hospital, but palliative care is essential part of the process for these patients that we see who are so acutely ill. So thank you again.